All right, folks, I think we've given people about 5 minutes or so to come in, so we may still see a few people coming in and through, but we'll get started. I'm very happy to welcome you today to Acentra Health's latest webinar. My name is Scott Fortin. I'm the Senior Director of Communications and Outreach, and I'll be moderating the call today. And our title today for the webinar is Unlocking Insights, Exploring Medicare Skilled Nursing Facility Appeal Trends and Lessons Learned. And our speaker today will be Dr. Jessica Whitley, our Chief Medical Officer. So before we get started, as I mentioned, we have quite a few folks on the phone and quite a few more that have even registered that will probably be coming in. So with that many folks, we have taken the opportunity to take the chat and microphone functions offline to get around the unfortunate unmuting or anything of that nature, and many times the chat being a little bit busy on the side so that we can concentrate on the slides that we're doing during the presentation. If you do have questions during the presentation, we're going to ask that you use the Q&A function that you see at the top there. We're going to try and answer as many questions as we can today during the session, and the remainder are going to be placed on our website along with the recording of the live session. So we will send you information on that. The slides will be available for download after the presentation, and we'll send that website link that I just mentioned via email to you as someone who attended. So again, thank you for your attendance today. So as I mentioned, our speaker today will be Dr. Jessica Whitley. She is the Chief Medical Officer for the BFCC-QIO contract. She is a board-certified internal medicine doctor. She's got over 20 years in clinical experience, and she's been with us at the QIO for about 12 years. And because we like to keep it a little light once in a while, one of the greatest fun facts that we have about Dr. Whitley is she makes the best New Orleans-style red beans and rice. So if any of you want to know anything more about that, you'll have to contact her directly. But I don't know much about red beans and rice myself. But with that, Dr. Whitley, I will turn it over to you.
Thank you so much, Scott. Can you hear me clearly?
Yes, I can hear you.
All right, fantastic. So let's get to business here. Let me just say to start off, for all of our Louisiana participants that may be on this call, or anybody that's from Louisiana or knows somebody from Louisiana, I know that my fun fact may be a little bit controversial, okay? I'm from New Orleans, and anybody from that area knows that we have debates all the time about who can make the best red beans and rice. So, of course, I put my hat in the race. My red beans and rice are really, really good. I did not throw my hat in the race for the best gumbo because I'm not even close to competing on that front. So anyway, thank you all for joining today's presentation. Today, I am going to share trends from data that we track from the skilled nursing facility appeals that we get, and we're going to explore the importance of these trends. We're also going to review Medicare coverage guidelines for the skilled nursing facility or SNF setting. We're going to outline Acentra Health's approach to making determinations for SNF appeals. And finally, we're going to present some lessons learned to enhance the care of beneficiaries in the SNF setting and to improve medical record documentation of that care. Now, the Beneficiary and Family-Centered Quality Improvement Organization, which is a mouthful, so it's also referred to as the BFCC-QIO, we are part of the largest federally coordinated infrastructure for improving healthcare across the nation. Acentra Health is the BFCC-QIO for 29 states, which are colored here on the map. So we collect and analyze both quantitative and qualitative data from beneficiary appeals throughout our states in order to identify trends and the potential factors that contribute to these trends. So this analysis is really, it's fundamental to devising targeted interventions that ensure the effective and efficient delivery of healthcare services to Medicare beneficiaries. One of our goals is to enhance the quality of care delivered to Medicare beneficiaries while optimizing resource allocation within the Medicare program. In order to achieve this, we recognize the importance of combining quantitative and qualitative data insights. Numbers can tell us part of the story, but they do not capture the entire picture. Therefore, Acentra Health made programmatic changes to our proprietary appeals processing system, and it facilitated the collection of qualitative data that focuses on the clinical characteristics of our beneficiaries. It has enabled us to gather these key clinical characteristics for 100% of the appeals reviews originating from the SNF setting. So I think that that's a really big deal, and that it will provide us with a wealth of information to help us to improve beneficiary care. So let's look at one of the trends that we've noticed. It is notable that there has been a significant increase in the volume of appeals from March of 2021 through July of 2024. Along with this increase in the volume of appeals, we've also noted an increase in our rate of disagreement with notices of Medicare non-coverage. So an important question becomes clear. What's driving these increases? One thing that I want to point out is that when we look at appeals coming from original fee-for-service beneficiaries, that volume of appeals has really remained stable during this time period at approximately 1.2 thousand appeals per month. So really this volume increase that we see is driven by appeals from beneficiaries enrolled in Medicare Advantage plans, also referred to as MA plans. One thing that we looked at is MA plan penetration. That has steadily increased since March of 2021. On the next slide, I'm going to show you the average penetration, but I want to review a little bit of the yearly penetration so that you can associate that with this upward volume trend. So in March of 2021, MA penetration in our states was 43%. This increased to 47% in 2022, to 50% in 2023, and it currently sits at 51%. Now, of all of the appeals that we get, 81% of our total appeals volumes originates from the SNF setting. So it seemed logical for us to focus some attention on the SNF setting because we're getting 81% of our appeals volume from that setting. And when we focused on appeals from the SNF setting during this time period, that's March 2021 through July of 2024, we looked at some averages. 90% of the appeals that come in that SNF setting, 90% of these come from beneficiaries with MA plans, despite an average MA penetration of 48% during this time period. We also noted a significant 12-day difference in the average length of stay for Medicare beneficiaries enrolled in original fee-for-service compared to those enrolled in MA plans. This average length of stay remains relatively stable for MA plan beneficiaries. If you look at that bottom line graph, you see that it doesn't really go up or down very much. But when we look at that average length of stay for beneficiaries enrolled in original fee-for-service, we do see more variability. It's not as obvious on this slide because of, our number axis on that y-axis. But when we've looked at it on other axes, we do see a lot more variability. And I think some of that is apparent to you now. So understanding this difference is really vital as we strive to improve patient outcomes, ensure access to care, and manage healthcare costs effectively. Now, before we look at our qualitative trends, I want to make sure we're all on the same page. So I want to ensure clarity and understanding regarding Medicare's coverage guidelines for patients admitted to skilled nursing facilities. These guidelines are found in the Medicare Benefit Policy Manual in Chapter 8, Section 30. So first, Medicare will cover care in a skilled nursing facility only if all of the criteria outlined on this slide is met for at least one skilled discipline. And of course, the skilled disciplines include skilled nursing, physical therapy, occupational therapy, and speech therapy. So the first coverage guideline is that a beneficiary must require skilled services. What does this mean? It means that their care requires the specialized skills of trained professionals due to its inherent complexity. It is really, really important to recognize that if a beneficiary requires only non-skilled routine care that can be administered by non-professional staff, Medicare will not cover their stay in a skilled nursing facility. Second, beneficiaries must require these skilled services on a daily basis. For skilled nursing services, this means that services are needed 7 days a week. If coverage is based on the need for therapy services, be it physical, occupational, or speech therapy, then skilled services for the covered therapy discipline must be needed 5 days a week. And let me make this point clear. It is not appropriate to arbitrarily stagger the timing of the various therapy disciplines so that you can cumulatively get to 5 days a week. What do I mean? We're going to do physical therapy 2 days this week, and we're going to do occupational therapy 3 days this week. So that means we've reached our 5 days. That does not meet the daily requirement when those therapy disciplines are arbitrarily staggered. There are certain rare circumstances where a beneficiary's clinical condition may warrant the staggering of those services, but that should be the rare exception and not the rule. I also want to note that Medicare policy states that this daily requirement should not be applied so strictly that it would not be met merely because there's an isolated break of a day or two during which no skilled rehabilitation services are furnished. For example, a beneficiary is not feeling well and can't participate in therapy for 1 or 2 days. Well, just because they didn't meet their 5 days for that week because they couldn't participate for 1 or 2 days, that does not mean they're not meeting this daily requirement. Now, of course, if a beneficiary is unable to participate either because of an illness or because of a simple, they don't want to participate, and this is not an isolated break, then that certainly may impact whether or not they're meeting this daily requirement. Third, skilled services need to be delivered in an inpatient skilled nursing facility setting. So this requirement is based upon practical considerations of economy, efficiency, and effectiveness. It's clearly not feasible or practical to provide intense daily services in a less intense setting if it results in an excessive physical hardship, higher cost, or diminished effectiveness. And lastly, all services provided must be reasonable and necessary. And this is judged by standards of medical practice and against the backdrop of the patient's specific clinical needs. This was a brief summary of the requirements. So please, for any further details or clarifications refer to the Medicare Benefit Policy Manual, Chapter 8. This is available online. So what's our approach at Acentra Health to applying these guidelines that I just talked about to the review of a beneficiary's medical record in order to make appeals determinations? Let me tell you, we're going to be very transparent here, and I hope that that can help you with understanding our process, and I hope that it can understand how you provide care. If there are Medicare Advantage plans on the call, hopefully it can help you when you issue notices of Medicare non-coverage. Also for skilled nursing facilities, you are the ones that issue Medicare notices of non-coverage for beneficiaries enrolled in original fee-for-service. So transparency is really our goal in order to further and enhance beneficiary care. So what do? When we receive an appeal, our peer reviewers, and let me note that our peer reviewers are independent contractors with active patient care practices. So they are still actively involved in patient care. And they are the ones that will review these appeals. They're a special team, they've been trained, and they handle these appeals. So this peer reviewer is initially going to do a comprehensive evaluation of the medical record that's been sent to us. They're going to initially assess both the clinical condition that resulted in the admission to the SNF, and they're going to look at the beneficiary's clinical status at the time of the appeal. This is crucial because it's going to help us to assess if the services being delivered are consistent with the nature and severity of the beneficiary's illness or injury, and it's going to allow us to determine the necessity of daily skilled nursing service. It can also identify any clinical issues that may affect the beneficiary's ability to engage in therapy. So we're first going to start with, how is this beneficiary doing clinically? What are the conditions that are being treated? Why are they receiving the skilled services that they are receiving? And what's their current clinical condition? And are the services matching up to that current clinical condition? Next, our reviewers focus on the beneficiary's functional mobility. We compare their mobility status prior to their illness or injury, at the time of admission to the SNF, and at the time of the appeal. This comparison is really vital in understanding a beneficiary's progress and to understand and evaluate the effectiveness of care that they are receiving. Now, although we do assess a beneficiary's progress, I want to emphasize, let me put flashing lights around this. It has to be noted that skilled care does not turn on the presence or absence of an individual's potential for improvement, but rather on the beneficiary's need for skilled care. So we do look at progress, but we're not looking at progress in order to determine, is this patient improving? And if they are not improving, then that automatically means they no longer require skilled services. It's something that we look at along with other things to determine a beneficiary's need for skilled services. Following this, we are going to look at the goals that have been established by therapy, and we're going to evaluate how the beneficiary's current mobility aligns with these goals. We then are going to look at the specific skilled modalities that are being employed by the therapist, and these are usually noted in the most recent treatment notes. So we're going to look at those most recent treatment notes to say, what are they doing? What are the modalities that are being employed? And our goal here is to assess the skilled need of that beneficiary and the types of skilled services being delivered. Finally, we recognize that there are instances where a patient's clinical condition results in a current level of function that's significantly worse than their prior level of function. and there really is no expectation for improvement within a reasonable time frame. In such cases, it is vital that we see documentation of established maintenance programs and or teaching and training of beneficiaries and their caregivers. Not only is the assessment and the implementation of therapy modalities a skilled service, but the establishment of maintenance programs is also a skilled service. Teaching and training is also a skilled service. So when we look at these beneficiaries that are not making substantial improvement, you must stop and say, should we implement a maintenance program, and does that beneficiary and or their caregivers need teaching and training to help them to adjust and function at this beneficiary's new mobility level? So that is so important to look and see if these maintenance programs and if training has happened for beneficiaries who have significant mobility deficits at the time of their appeal. Now, I noted previously that our data analysis not only involves quantitative data, looking at the numbers, it also involves qualitative data. So our qualitative data focuses on the clinical characteristics of our beneficiaries. This qualitative data that I'm presenting today is based upon information abstracted from all SNF appeals that have been received between May and July of 2024. This totals 45,941 cases. The reason that we've collected this data from May to June is because the current BFCC contract began on May 1st, 2024. So this data represents our current contract to date data. One of the things we monitor are the diagnoses that drive admissions to SNFs. 3 diagnoses account for approximately 50% of all admissions to skilled nursing facilities. These include beneficiaries who have injuries or surgeries related to their lower extremities, beneficiaries recovering from acute infections, and beneficiaries with generalized weakness. Interestingly, at least interesting to me, beneficiaries who suffer strokes often require rehabilitation services. It was surprising that they accounted for a small percentage of admissions at only 5.46%. We also trend the mobility characteristics of our beneficiaries, one of the most telling being walking distance. We trend beneficiaries' walking distance at 3 crucial points. We look at their level of function before they entered the skilled nursing facility, so before the onset of the illness that occasioned that admission to the skilled nursing facility. We look at their mobility at the time of their admission to the SNF, and we look at their mobility at the point when the notice of Medicare non-coverage has been issued and they're filing the appeal. Now, the findings from our analysis are quite revealing. At their prior level of function, approximately 60% of Medicare beneficiaries were able to walk distances greater than 100 feet. So this reflects a level of mobility that allows for a relatively independent lifestyle. However, by the time these beneficiaries file an appeal, this figure drops sharply to around 25%. This significant decline illustrates a marked reduction in their mobility. This marked reduction in mobility is also demonstrated when we look at beneficiaries who can only walk between 0 and 10 feet. At their prior level of function, these beneficiaries make up about 26% of the population we analyzed. Yet, at the time of appeal, this percentage jumps to 43%. So 43% of beneficiaries that are filing appeals because they have received notices of Medicare non-coverage can walk less than 10 feet. In addition to distance, we trend the level of assistance required for walking. Initially, most beneficiaries, 85%, as illustrated here, need only contact guard or lower level of assistance to walk. This means they could walk independently or with a little help. However, by the time of the appeal, the number of beneficiaries needing more than contact guard assistance rises significantly from 15% to 49%, meaning these beneficiaries require around 25 in between 25 to 100% of the work of walking to be performed by someone else. They cannot perform the work of walking by themselves. They need someone to actually perform part of their work. This tells a powerful story about the challenges faced by Medicare beneficiaries when they receive notices of Medicare non-coverage and when they're filing these appeals. The significant decline in walking distance and the increase in required assistance underscore the fragility of this population and the critical need for support. And despite this fragility, the medical records that we review rarely contain established maintenance programs or evidence of beneficiary caregiver training. Now, that may be because the skilled nursing facility and the providers in that facility were not expecting a notice of Medicare non-coverage to be issued. But these are some of the things that we're presenting so that we can share these with this community that is that are stakeholders for the care of beneficiaries in the SNF setting, so we can try to get down to some of the whys, and the answers to some of the whys can drive some of the whats. What should we do about this? And some of the hows. How can we improve beneficiary care? How can we improve when notices of Medicare non-coverage are issued? How can we improve our appeals process? Another thing that I want to present is that a significant decline in walking distance from the beneficiary's prior level of function may suggest that the beneficiary requires ongoing skilled care to continue improving or at least maintain their current level of function. So when we're looking here at this data, when our physician reviewers agree with notices of Medicare non-coverage, it's observed that most beneficiaries can walk approximately 100 feet at the time of their appeal. This distance, although potentially reduced from their prior level of function, suggests that the beneficiary has made sufficient progress and no longer requires intensive skilled services in a SNF setting. And therefore, that supports the decision to discontinue Medicare coverage. Now, in cases where our physician reviewers disagree with the notices of Medicare non-coverage, beneficiaries can typically only walk 35 feet on average at the time of their appeal. And that's compared to an average prior level of function of being able to walk greater than 100 feet. Now, this significant reduction in walking distance suggests that these beneficiaries may not have sufficiently recovered and may still require ongoing skilled care to improve their mobility and prevent further decline. Their limited walking ability may indicate that they're just not ready to transition to a lower level of care, and that supports the decision to continue Medicare coverage. Now, I want to emphasize something. So again, let me put my highlights, my flashing lights. We are only presenting one of the mobility characteristics that we are trending. We trend other mobility characteristics, including transfer abilities and levels of assistance needed for transfers. We trend whether or not beneficiaries are using wheelchairs and how far they're going in wheelchairs. And even beyond what we are trending, we certainly do not base our appeals determinations on any one particular mobility goal. Our physician reviewers look at the entire medical record and all therapy goals and skilled nursing needs prior to making a determination. So, what have we noted? We've noted a couple of important things. We've noted that our appeals volumes has been rising along with our disagree rates. And we've also noted that beneficiaries' mobility status appears to be significantly impaired when notices of Medicare non-coverage are issued. So based upon the trends that we're seeing, we've identified some lessons learned that will hopefully promote the delivery of high-quality patient-centered care in SNF settings. The first lesson is the fact that discharge planning is an essential aspect of care. Established goals of care should be influenced by the discharge plan, and the discharge plan should be influenced by a beneficiary's progress towards those goals. Discharge planning should be a fluid process, and it should change according to the beneficiary's needs. What we see when we review these appeals is we see in the initial therapy assessments that there is a discharge plan, and rarely do we see that there is a mention of that discharge plan anywhere else in the medical record. And that's independent of how the patient is doing. So one, if discharge planning is not being thought about through that admission and that stay, this could represent a significant lapse in meeting beneficiaries' needs. It can also impact whether or not therapy goals are being appropriately made and or changed based upon what the discharge plan is. In line with this discharge planning goal is a second lesson, and this involves the realistic setting and modification of goals for beneficiaries. The Medicare Benefit Policy Manual talks about this. It talks about this, Chapter 8, and I'm giving you even the section 30.2.2.1. It states right there that if it becomes clear that the goals initially set for a patient are no longer practical, reasonable, or necessary, they must be promptly and appropriately modified. This revision of goals should be documented in the medical record, and the patient should be reassessed to determine whether the revised goals still require the provision of skilled services. So this approach ensures that care remains aligned with the patient's evolving need. Scott introduced me in the beginning. I'm board certified in internal medicine. For my career, I practiced as a hospitalist physician. Therefore, I took care of patients in the hospital. And just give you an example, if I'm treating somebody for a pneumonia and I've selected an antibiotic, I'm treating them with one particular antibiotic, I need to watch the effectiveness of my planned treatment. If my patient continues to have fevers, if their oxygenation continues to be poor, if their white blood count does not decrease and remains the same, if their respiratory rate is still high, I need to say, wait a minute, my initial plan was to treat with antibiotic A, but maybe antibiotic A is not working. I need to change, and I'm going to switch my therapy plan to now I'm going to change to antibiotic B. And maybe I need to involve pulmonary. So I'm saying this to say this is the same thing when we're looking at patients in skilled nursing settings. We don't just set these goals and keep these goals no matter how the patients are responding to these goals. If we see that they're not responding and they don't seem to be making any progress, we must ask ourselves, do we need to change the goal? Or do we need to change the modalities that are being employed to accomplish these goals? It's really helpful if we see this in the record and we know that this type of thought process is going on. Third, when a beneficiary has reached a new baseline with significant impairments in their mobility that's very different from how they were functioning prior to this SNF stay, it is essential for SNF providers to develop a maintenance program and or provide patient and caregiver training. This is crucial in ensuring that the beneficiary receives appropriate care that meets their current needs. Fourth, it's important to evaluate both the skilled nursing and skilled therapy needs of the beneficiary. There are times when beneficiaries may have met all of their therapy goals. I mean, they're walking 250 feet, they're transferring by themselves, they're bathing themselves well, they can dress themselves, they're feeding themselves. I mean, they look great from a mobility standpoint. However, if you look at the clinical note from the skilled nurses, there's this note that says, Mrs. Jones is complaining of increasing shortness of breath. We've noted that she's got increasing lower extremity edema, and I'm going to call the doctor. The doctor says, let's look at her weights. We see that her daily weights are increasing. She's got a known diagnosis of CHF. So the doctor says, we're going to increase her Lasix dose, and I want you to continue to monitor her symptoms of shortness of breath and the lower extremity edema. So we have seen that sometimes and oftentimes when we get notices of Medicare non-coverage and when we get the detailed explanations of those non-coverage, it focuses purely on how a patient is doing in therapy. And oftentimes when patients have had changes in clinical condition, these changes are either not recognized or not appreciated as being a sign that further skilled nursing care is needed. So please pay attention to changes in clinical condition and make sure appropriate skilled nursing care is being administered. It may justify continued skilled nursing care. We've often seen certain extreme cases that patients need to be transferred back to an acute care facility. So it's easy to get focused on therapy needs, but we have to look at the entirety of the patient's care, and that involves their clinical condition as well. Next, it is so important that we recognize that this, quote unquote, improvement standard that had been used for a long time by Medicare contractors and by providers of care is outdated. And there was re-education provided by CMS following the Jimmo versus Sebelius settlement. And it clarified that Medicare coverage for skilled nursing and therapy services is not contingent on the potential for improvement. Instead, coverage is based on the beneficiary's need for skilled care. And that skilled care can be needed to improve, to maintain, or prevent further deterioration of the patient's condition. And a lot of times, if we think about in order to improve, in order to maintain or prevent, sometimes the skilled need is teaching and training. So please don't get hung up on the fact that if a beneficiary is not improving, they no longer qualify for skilled care. That is absolutely not the case. Finally, one of the most critical aspects of our appeals process is the medical record documentation. We are not seeing these beneficiaries. We cannot examine the beneficiaries. The picture of the beneficiary and the care that they need and the care that's being provided is only going to be painted through medical record documentation. So this documentation is not merely a formality. It's really the linchpin in determining whether or not continued daily skilled services in a SNF setting are reasonable and necessary. And this is emphasized in Title 42 of the Code of Federal Regulations. I've even given you the section here too. It's section 405.1202, section D. And it says, when a beneficiary requests an expedited determination by a quality improvement organization, the burden of proof, let me say that again, the burden of proof falls squarely on the provider. It is the provider's responsibility to demonstrate that termination of coverage is the correct decision. And this is whether it's based on medical necessity or other Medicare coverage guidelines. So this burden of proof can only be met through thorough and accurate documentation in the medical record. It is vital that this documentation is up to date. Specifically, I will tell you that at Acentra Health, we require that we receive documentation that is no older than 7 days prior to the date that the services will end. This ensures that we are making our determinations based on the most current and relevant information at the time of that appeal. And that's going to support accurate and fair appeals determinations. Thank you so much for your attention. We presented this information to contribute to our shared dedication to the well-being of the Medicare population. And, together, I really do believe that we're all striving to continuously improve the delivery of quality, efficient, and effective care. So I hope that this presentation serves as a reminder that the work that we do every day is not just about meeting regulations, but it is about making a profound impact on the lives of our beneficiaries and their families. So now let's take some questions. Scott, do we have any questions?
Yes, thank you, Dr. Whitley, for that information. We do have some questions. For those that have come in a little late, a few housekeeping reminders. Please submit any questions that you have under the Q&A button at the top. There is not a chat or a microphone feature. Those do remain muted at this time. We're going to answer as many of those questions as we can in session, but as a reminder, the rest of those will be posted to the site along with the slides from today, and those will be sent out to folks that have attended this, as well as being open to everyone on our web page. So if you do have additional questions also, we will leave this session open as long as we can. So you can continue to hit that Q&A button and ask your questions there. If you do have questions that are outside of this particular presentation for us, or if you missed the time, if we happen to close up the teams here before you're able to answer or get all your questions asked, please feel free to send those to QIOcommunications@acentra.com. So with that, Dr. Whitley, I've collected a few. So the first one here is how do you approach cases when a patient cannot walk because they have like weight-bearing restrictions?
Oh boy, that's a very interesting question, and that's an excellent question. And it is a question that comes up often. So typically the scenario that we will see, and this question may have come up because we focused on walking distance. Let me reiterate that walking distance is certainly not the only mobility goal or mobility characteristic that we focus on. There are a variety of other mobility goals that we look at. We really look at the totality of the patient's clinical and functional status. But let me start by saying, here's a clinical example, and we see these cases often. Say, for instance, you've had a patient and they've just had a repair of a hip fracture, and they are on non-weight bearing status. So that means they cannot put any weight on that extremity that's been operated on. So of course, in those situations, walking distance may not be the goal that should be being focused upon. And I'd like to really emphasize this if we have therapists and providers of SNF services on the call. In this particular situation, because a patient's not weight bearing, a lot of the therapy goals may be more appropriate to focus on their transfer ability, because there's more ways to get around than just walking. Perhaps while this patient cannot walk, they're going to have to move around in a wheelchair. So then it would be more appropriate to see wheelchair goals and distances of getting into a wheelchair and propelling themselves in a wheelchair, and transfer goals to ensure that that beneficiary can safely transfer from the bed to get into the wheelchair. So in those situations where a patient cannot bear weight, we are aware that the goal that we need to be paying attention to really is not the distance that this beneficiary is able to walk, but it's those other goals that will keep that beneficiary safe, that will make sure their condition doesn't decline, until they can regain that ability to bear weight. I hope that answers the question. Certainly, if you have follow-up questions, feel free to submit that in our Q&A feature. Any other questions, Scott? Scott, if you're talking, you're on mute, I think.
Thank you, Dr. Whitley. Was gathering a couple more questions for you. We do have a few here that we can cover in our time. The next one we have is, we have many beneficiaries who no longer need skilled care, but are only able to walk 50 feet with minimal assistance. What would you need to see in that documentation to agree with the NOMNIC?
Excellent question. So this really is something that I refer to, and thank you, questioner, because you put a clinical situation to something that I described in without a clinical reference. So I talked about those beneficiaries who have reached a point that their current level of function is a lot lower than their baseline level of function. And to think that they are going to improve, they're not going to improve in any reasonable amount of time. Their improvement may be over a longer period of time. So what do you need to focus on in the skilled nursing facility when you see this? So if somebody was able to walk around community distances, they were able to go 300 feet, they didn't need a walker, they didn't need anybody to assist them before, and they've had some type of injury or illness, and now they've been getting skilled therapy, but they're only able to walk 50 feet now, and they need minimum assistance. So what we're looking for is, one, what has been put into place, and that can be via a maintenance program. What has the therapist done to say, you are at a new baseline that's much lower than your prior level of function? And you may continue to need skilled services, but these skilled services are no longer needed on a daily basis. So what do we need to make sure you are going to remain safe at home so that your condition is not going to decline and we can maintain you where we are while we may continue skilled services, intermittently, and you may gradually improve? That's where a maintenance program is really, really essential. And that's where teaching and training can become really essential. Because if somebody still needs minimum assistance, they may need up to 25% of the work of that walking to be done by somebody else. It's, a skilled therapist can teach and train a family and or a caregiver of how to provide that additional support to that patient, to assist them and to make sure they're going to remain safe. So in those situations, that's not an automatic somebody's 50 feet and they require minimum assistance, so they have to stay. That's not how we make these determinations. We're going to be looking in the record of, yes, they have impaired mobility. This impaired mobility does put them at risk for a decline in condition. They could go home, they could fall, they could break something else, they could get a head injury. So we're looking to see, has therapy put in a maintenance program and or family or beneficiary or caregiver training to at least try to ensure as best as possible that this beneficiary's condition is not going to decline. So again, I hope I answered that question. If I haven't, please put some follow-up questions in that Q&A feature. Any more questions, Scott?
Yes, for sure, Dr. Whitley, on following up on that. Thank you, folks. We are getting a decent number of questions. I did also want to, before I throw another one to you here, I did want to direct everyone's attention to the Q&A. If you have touched that button, you'll see that there is a program feedback link in there for Acentra SNF Appeals Program. So we really would like to hear what you thought about today's presentation. So I would ask in our time, if you would like to, you could fill that out, or like I said, we'll be around for a few minutes afterwards, after we've closed the presentation portion, for you to be able to give your feedback to us. The next one here, Dr. Whitley, as I scroll up, is what do you do with patients who are not making progress because of self-limiting behavior and decreased functional participation?
Boy, you guys ask some great questions. So this is a really unfortunate situation. And we have seen it. We actually have seen beneficiaries that have significant therapy needs. And there are some beneficiaries who simply say, I don't think this is not helping me. I'm not participating in this. Now, if they are refusing to participate in therapy, then they are not meeting that daily requirement. In those cases, we do look for evidence in the medical record that they have been properly informed. Listen, you're continued, because remember, I said that an isolated break in therapy, are they having a bad day? Is something going on with there's like, I just can't participate today. So an isolated break of 1 or 2 days should not make you say they're not meeting this daily requirement. However, if this is more than an isolated break, then the beneficiary should be informed that not participating then makes it such that they are not meeting a required Medicare coverage guideline, and Medicare will not continue to cover that stay. I want to separate the patient that's unwilling to participate with the patient that is unable to participate. Now, when patients are unable to participate, and let me give you a clinical example that I saw before. So you had a beneficiary that was participating and making progress in therapy, and then suddenly she started getting more confused. The daughter was at the bedside. She was saying, hey, my mom is more confused. She typically acts like this when she has a UTI. So now it's been about 5 days that she hasn't been able to participate in therapy, but they did send a urinalysis. The mother did, in fact, have a UTI, and the mom had a low-grade fever. So now when we're looking at the appeal, that beneficiary is no longer meeting that daily requirement for therapy services. So she would not meet the coverage guidelines for therapy services. However, her driving force and her driving need for continued skilled care, for continued skilled services in the SNF becomes her skilled nursing needs, because skilled nursing is observing and assessing her condition. They're seeing, is she responding to this antibiotic? Is in fact the UTI the reason for the increased confusion? Are we going to have a worsening in this patient's condition that either that's going to necessitate transfer back to an acute care setting, or are we going to have to say, hey, maybe we're wrong and the UTI is not causing the confusion, and therefore we need to do further workup or evaluation for this patient? So it doesn't mean that a patient who is unable to participate in therapy doesn't mean that their SNF coverage should end. It just means that they're not qualifying for that stay in a SNF based upon their therapy needs any longer, but they're qualifying based upon their skilled nursing needs. Again, I hope that answered the question. If it hasn't, send us some follow-up questions in that Q&A. And Scott, I'm not sure if we have time for any more questions, but I'll toss it back to you.
No, unfortunately, Dr. Whitley, we're at the top of our hour. So to be respectful of everyone's time and our timing for this, we greatly appreciate all of your participation today. And again, we'll stay on for a few minutes here. If you could complete that program feedback for us, that would be great. But again, to reiterate to you, we've gotten some really good questions today, some that we've been able to get to Dr. Whitley and some we have not. So we will make sure that we reach out to all of you that have attended with that link for our website and provide you with both the slides and the responses to the questions that you posed. Again, we thank you so much for your time, and we look forward to hopefully seeing all of you at another program in the future. Have a great day.